It's late at night in Monroe County, Pennsylvania. Most people are asleep, but Sarah, a 20-year-old student, is still awake, staring at her phone. She has her life all planned out: college, a great career, and traveling. But tonight, she is looking for help, and all she sees on the map is empty space. Sarah wants an IUD. She knows it's the best way to make sure she doesn't get pregnant while she's still in school. But in Monroe County, where 16,000 people live, there isn't a single public clinic that offers them. To find one, she has to leave the county and go to Wilkes-Barre. But Sarah doesn't have a car. The local buses are hard to find, and they don't run often. Then she sees the price, $1,500. For a student working a part-time job, it's nearly impossible. She feels like her future is being blocked by a wall she can't climb.
Hi everyone, welcome back to our podcast, Rethinking Women. I'm Jessica, your host for today's episode. Sarah's story is shared by the 19 million women in the United States who live in what we call contraceptive deserts, counties where women lack reasonable access to a health center that offers a full range of contraceptive methods due to a shortage of publicly funded health centers. This is what we're going to be focusing on today. How does the contraception desert phenomenon in rural U.S. counties affect young women's educational and career trajectories compared to their urban counterparts? In today's episode, I'm joined by two guests to dive deeper into these barriers. Guest one is Kiki, a socioeconomic analyst. Welcome.
Hi, I'm Kiki. Thanks for having me.
And guest two is Dan, a public health observer.
Thank you. Hi, I'm Dan.
So here's our plan. We're going to unpack the three primary barriers that prevented Sarah and all the other women in the same situation as her from getting birth control, as well as the corresponding consequences. We're going to unpack the barriers one by one. First, the financial wall. Second, the stigma and the knowledge gap. And lastly, the geographic barriers and policy failures. Let's get right into it. So Kiki, Sarah saw $1,500 USD for an IUD and closed her phone. For those unfamiliar, IUDs, or intrauterine devices, are a form of contraception that is inserted into the uterus to prevent pregnancy. So walk us through the real economics here. Is that number accurate? And was she wrong for walking away?
Yes, the number is accurate, even conservative. Actually, the upfront cost of an IUD is $1,552 plus the implant cost, which together is $1,500. Obviously, for a part-time student who makes $11 an hour, it is unaffordable. Now, let's look at what Sarah probably bought instead. First, the pill. Without insurance, the upfront cost can go up to $100. That sounds cheaper, right? But it lasts just 30 days. Over 1 year, the pill cost $1,200. Others may use the patch, which costs about $1,800 a year. However, $1,500 IUD sounds expensive, but it lasts 3 to 10 years, depending on its type. So, spread out over time, the IUD costs about $135 per year. More importantly, the typical use failure rate for the pill is about 9%. For the IUD implant, it is just 0.1%.
So what you're saying is that the cheap option is actually more expensive in the long run.
Yes, exactly. It is what economists call the poverty tax. When you can't afford the upfront costs of quality, you pay more over time. Rich people can afford a $1,500 IUD that works for a decade, while poor people can only afford the $30 sponge that fails tomorrow. So according to the data from the Affordable Care Act, it helps women with private insurance save roughly $1.4 billion annually in contraceptive costs. That's what women would have to pay themselves if insurance didn't cover it. That shows how big the problem is.
So Sarah, who might not have that coverage or who lives in a state with restrictions, is bearing the full weight of that system.
Yes, despite their effectiveness, access to long-acting reversible contraception or LARC methods like IUDs remain limited due to the barriers such as high upfront cost and a shortage of providers trained to insert them. Sarah didn't feel the system failed her. She made the rational choice with the money she had, but the system made the choice a trap.
So even though Sarah wants an IUD, she is unable to afford one. Dan, does the financial barrier connect to something bigger?
Absolutely. Because money is not just money. Money determines where you can live, what information you can access, and whether you can take a day off.
Yes, we will discuss the geographical issues later, thank you. But first, let's talk about the second obstacle Sarah encountered.
Since Sarah couldn't afford the clinic or the trip, she tried to find another way. But in her small town, talking about birth control feels like sharing a dirty secret. Her high school never really taught her about sex or health. It was mostly just don't do it. She was afraid to go to the local pharmacy because she didn't want the staff to judge her. She didn't have a doctor she could trust, so she asked her friends for advice. But her friends didn't really know about the facts either. They told her myths they saw on social media. Because there was no Title X clinic nearby to give her real information, Sarah was just guessing. She ended up picking a birth control method that was easy to get but not very strong. She hoped it would be enough to keep her dreams alive.
Clearly, Sarah was ashamed to talk about birth control and sex because this was deemed a taboo topic. Dan, this is the classic social and educational barrier. Walk us through what's happening here.
This is what we call a knowledge desert. It's just as dangerous as a real desert. Sarah said that she relied on friends and social media to obtain information. However, they may not have a comprehensive or accurate understanding of contraceptive knowledge, which could lead to the spread of incorrect information. She wasn't being stupid, she was being isolated.
So, Sarah was isolated from proper education and could only rely on the limited information from the people around her. Then what about the school?
I think the school let her down. Because the state doesn't require comprehensive sex education, schools have different policies on teaching students about birth control. Each local school district gets to decide on its own whether to keep teaching only abstinence.
So, not a single word about IUDs, implants, or even how to access the pill. You can't preach abstinence and prevent sex when students are not educated on the consequences. This is drastically different from schools where sex education is mandated. And what about the community stigma?
This is a great significance. Religion and personal beliefs can have an impact on an individual's decision regarding contraceptive methods. In Jefferson County, there is a widespread negative perception of contraceptive method. This negative perception may prevent some people, especially young people, from seeking a contraceptive method and may also prevent them from discussing reproductive health issues with their peers and healthcare providers. So Sarah is afraid to walk into the local pharmacy because the staff might know her family. That's not a paranormal, that's a real barrier created by her community's culture.
Interesting. This is actually similar to how the Trump administration harmed the Title X program. For those unfamiliar, the Title X program is a U.S. federal grant program established to provide confidential and affordable family planning and preventative health services to low-income individuals. The Trump administration undermined minors' rights by pressuring staff to involve their families in contraceptive decisions. As Dan mentioned just now, the significant community stigmatization often discouraged young women from seeking out essential resources even when they're in need. This led to roughly 1,000 clinics leaving the program, significantly reducing patient capacity and access to contraception. This is especially harmful to regions like Monroe County, which already faced a shortage of clinics to begin with. That's not a medical failure, that's an educational failure. In this section, we can clearly see how, besides the contraception desert, women living in these regions also experience a knowledge desert. So now we have a financial wall and a knowledge wall. But Sarah also couldn't get anywhere. Let's talk about geography. Sarah lived in Monroe County, 160,000 people, but not a single IUD provider. Dan, how does this happen in the US in 2026?
It happens because of institutional barriers. This is the case in Jefferson County as well as in Monroe County. There are only two clinics in the county that provide publicly funded contraceptive information. This limited the access to such information for residents in the north and central part of the county. The county's public transportation system is very weak, with only one fixed bus route. This makes it difficult to travel to the clinics, especially for those without a private car and with limited financial resources. Sarah didn't have a car. The bus didn't run often. That's not an accident, that's a design failure.
Right, so besides the systematic financial barriers, even the geography prevents Sarah from accessing birth control. These fundamental barriers are deeply ingrained in the system, whether it be through oppressive policies or predatory prices. Dan, could you please elaborate on the policy barricades?
This is critical. In Jefferson County, the same policy failed to achieve equitable coverage. Although the Medicaid program covers family plan services, the organizational structure has flaws. Although federal and state funds are theoretically achievable, due to the lack of medical facilities and limited public health institutions in Jefferson County, the number of institutions capable of providing service has also decreased accordingly. The policy exists on paper, but there's no buildings, no nurse, no bus.
So lack of local health departments essentially equals lack of clinics.
Oh, yeah, exactly. And let me add one more piece. Most of Planned Parenthood's clinics are in rural areas or places with few doctors. And for 6 out of 10 women who go to places like Planned Parenthood, it's their main source of medical care. When those clinics aren't there, women don't have a backup plan.
So Kiki, what's the cost of this geography problem?
The cost is that Sarah couldn't get the $1,500 IUD. This would lead to the $90,000 costs of giving birth, plus the lifetime loss of income from derailing her nursing degree. That's the motherhood penalty. In reality, about 45% of the pregnancies in the US were unintended. That's 2.8 million pregnancies. Most of those were among women in their 20s, just like Sarah. This is not rare. It is an epidemic of failed access.
A few months later, Sarah is sitting on her bed, holding a plastic stick, 2 pain lines. That easy method she paid, it doesn't work. Now Sarah is one of the thousands of women who get pregnant because they couldn't get the health care they needed. She isn't thinking about graduation anymore. She's thinking about how she will pay for a baby when she can barely pay for her books. This is the motherhood penalty, and for Sarah, it started way too early. Sarah's story isn't just about one person. Right now, there are 19 million other women living in desert just like hers.
This brings us to our final discussion, which is what happens after. So let's talk about what happened to Sarah. Those 2 pink lines. Kiki, walk us through the motherhood penalty. What does that mean economically?
The motherhood penalty is a measurable loss in lifetime earnings that women experience when they have children, especially when they have them young or unintentionally or without support. For Sarah, she was on track to be nurse, but now she is likely to delay or drop out. She will work lower wage job. She will struggle to afford childcare, and then an unintended pregnancy in her early 20s can push her into long-term poverty. The worst part is that a $1,500 IUD could have prevented everything. Instead, we spent huge amounts on the result of unplanned pregnancy, like Med-Aid covered births and housing assistance, but we refuse to spend on prevention. That makes no financial sense.
Without birth control options, women risk unintended pregnancy. Unintended pregnancy is life-changing, especially during youth. So, Dan, what are the policy solutions? What would have saved Sarah?
There are 3 solutions. The first one is the Title X expansion. We need more clinics in rural area. The second one is the over-the-counter pillow access. All pillow is now over-the-counter, about $20 a month. That's not a long-acting reversible contraceptive, but it lowers the barrier. The third one is a comprehensive sex education mandate. The comprehensive and evidence-based sex education can delay the onset of sexual activity and encourage the adoption of safer sexual behavior.
So, Kiki, would these solutions save money?
Absolutely yes. Every dollar spent on contraception saves $3 in Med-Aid cost for unintended pregnancies. The IUD cost $1,500. The birth cost $19,000. The price is clear.
Clearly, there are possible and effective policies for local governments to adopt in order to address these current issues. The real question is why governments have not chosen to adopt these solutions yet. Whether it be due to traditional or religious values, economic greed, or simple oversight, it does not matter. What matters is the real consequences faced by women like Sarah as a result. Unfortunately, Sarah's story is not unique. Right now, there are 19 million other women living in contraceptive deserts just like hers, sharing the same experiences as Sarah, in counties all across America. They're doing the math on $1,500 that they don't have. They're walking past pharmacies where the staff know their mothers. They're relying on TikTok for medical advice because their schools taught them nothing. And they're holding plastic sticks with 2 pink lines, knowing the system could have prevented this. Zip codes should not determine a person's reproductive health, but right now they do. Thank you to Kiki and Dan.
Thank you.
Thank you.
Thank you to Sarah, whose story reflects millions of women. I'm Jessica. This is Rethinking Women. See you next time.